So, Ahmed, I think it's the time to start. Assalamu alaikum wa rahmatullah. Good evening, everyone. Back to the Dubai Shoulder course webinars. Today we have a very interesting subject to the people who is doing upper extremity mainly, and also to the trauma surgeon as well. We will cover the reverse shoulder arthroplasty in the two main indication of reverse shoulder arthroplasty, either in the rotator cuff arthropathy, which we will learn how to do it from Dr. Ludwig Seebauer, the chief of orthopedic surgery and the well-known shoulder surgery in Germany. He is the chief of orthopedic at Klinik am Bogenhausen at Munich. Then we will know what is the indication and how we manage the reverse shoulder arthroplasty in the trauma setting in the fracture cases by the well-known worldwide known shoulder surgeon, Dr. Philippe Valenti from Paris, France. And before going to these two subjects, we will hear from Dr. Saad Al Qahtani, a very nice introduction and very nice presentation about the basic science behind reverse shoulder arthroplasty and biomechanics. We'll start with Dr. Saad Al Qahtani, who is a good friend of mine. He did his residency program at McGill University in Canada. Then he did three clinical fellowships, one of them with George Atwell on upper extremity and shoulder surgery, and the other one in complex trauma surgery in University of Toronto. Let's start with Dr. Saad Al Qahtani with his presentation on the basic science behind reverse shoulder arthroplasty. Welcome, Saad.
Thank you for the invitation. I'll share my slides. Okay, I would like to thank you for the invitation. It's my honor to be with you guys in this webinar. I'll be talking about some of the basic science for the reverse shoulder arthroplasty. Before we go into the indication with Dr. Valenti and Dr. Seebauer. So I divided my talk about anatomy and basic definition. Then we'll talk about the conventional Grammont reverse. Then we'll talk about some of the design evolution over the time. Before we go into some basic biomechanics and Grammont implants, I would like to talk about anatomy and basic science because it's very important to understand the prosthesis itself. So when you talk about the humeral head, it's mainly a sphere. Some studies showed that it's partial ellipsoid. The average humeral head diameter is about 46.2, and there is always a constant ratio between the humeral head diameter and the humeral head radius. Most of the men get around 24, and it's about 19 in women. The average humeral head height is about 15. And as I said, there is always a constant ratio between the humeral head radius of curvature to the height, which is about 70 to 80%. As you can see here in this diagram, which also show the center of the rotation of the proximal humerus. What about the humeral offset? The offset is the position of the center of the rotation of the humeral head from the axis of the humeral shaft. And it has two planes, on the coronal plane and into the transverse plane. We have a combined offset posterior medially if you compare it to the long axis of the humeral shaft. As you can see here, the center of rotation is posterior and medial compared to the long axis of the humeral shaft. What about the humeral head retroversion? The retroversion is defined by the angle between the central axis of the humeral head and the epicondylar axis of the distal humerus. The average is about 28, and there is a variability on retroversion based on age, sex, races, and sometimes between both sides. As you see in the diagram here, this is the axis of the epicondylar distal humerus, and this is the axis of the humeral head. So it is about 28 to 30 degrees of retroversion. The inclination, when we talk about humeral head inclination, we mean the neck shaft angle, and it's ranging from 129 to 137 with an average of about 135 or 134.4. And this is an important concept to understand before we talk about the prosthesis. And this is a diagram showing that neck shaft angle. What about the proximal humerus morphology? It's variable. There is merely 3 distinct types of the metaphyseal morphology that considered the offset of the greater tuberosity from the long axis of the humerus, which is standard high offset or low offset. And the shaft itself can be cylindrical or a funnel shape. And this one showed the standard, the high and the low offset regarding the proximal morphology. Rotator cuff, it's important for any surgeon to understand the cuff and the insertion, which is very important when you do your cut for the humeral resection, and also for the subscapularis reattachment after doing the procedure. And finally, we'll talk about the glenoid anatomy. The average height is about 38 for men and 36 for women, and the average width is 29. Inclination range from 2 inferior tilt to about 4 superior tilt. Glenoid version, CT is the best modality. There's a different way, and it's about 5 degrees of retroversion. And nowadays we talk about vault retroversion more than the actual glenoid or the scapula. So after we talked about the anatomy, now we'll go into the basic behind the conventional or the Grimoire reverse shoulder arthroplasty. On the 70s, Neer was doing the total shoulder arthroplasty. He reviewed his series between the 70s and 81, and he found that there is a poor outcome when he's doing his total shoulder and having non-functional cuff. So in 83, Neer came out with the concept of rotator cuff arthropathy, which is a massive rotator cuff tear with structural changes in the glenohumeral joint, which is classified based on Hamada, which is known to everyone. And he noticed that there's a big difference between the arthritis when the cuff is intact, which is concentric, and when the arthritis happens when there is a rotator cuff tear where there's an anterior superior migration. So when there is a total shoulder arthroplasty and absence of functional cuff, there was a high rate of glenoid component failure due to edge loading, what we call a rocking horse phenomenon. So based on this observation, Neer suggested to have a hemiarthroplasty as a treatment, but subsequent literature and review showed that hemiarthroplasty for rotator cuff arthropathy was unpredictable with a very poor outcome and poor function. So from here, there was the need to develop the reverse shoulder arthroplasty to address this issue, to have a better outcome and a predictable function. And it was until 1985, there was some trials on the 70s, but unfortunately it all failed until Gramont came with his concept in 1985. And his concept basically was to have a prosthesis that is stable inherently. So the weight-bearing part is convex and supported, and the supported part is concave. The center of the sphere at or within the glenoid. So there is a medialization of the center of the rotation, and also distalization to have tension on the deltoid. And the name delta for his implant came from the deltoid because deltoid function increased by moving the center of rotation distally and medially. So there was some iteration in his implants. He moved his glenosphere from 2/3 of a sphere to about a half or 1/3, which increased the medialization of the center of the rotation toward the glenoid surface. His base plate was added a central breast fit with 2 divergent screws to resist any shear forces at the bone implant interface. So by doing this, by shifting the center of rotation medially and distally, the implant acts as a fixed center of rotation or deltoid into a rotatory movement or a compressive force. And as I said before, when you medialize the center of rotation, you increase the deltoid lever arm, which make it easier to have an abduction and forward elevation, and also by distalization, which increase the tension into the deltoid. And this photo explained the distalization, which put more tension into the deltoid and also caused some lengthening onto the upper extremity, which might have some effect into the nerve. The glenoid, he used a large glenoid between 36 and 42, which will increase the arc of the motion and the stability with a very small lateral offset, as I said, to resist any shearing force and have a stable base plate. By doing this, he recruits more deltoid for elevation and abduction, and with reverse in his implant, he noticed that the force for abduction was reduced by 30%. What was the disadvantage with the Grammont or the conventional arthroplasty? There is insufficient tensioning of the posterior external rotator, which will make the function a bit weak, or have a weak external rotation post these conventional arthroplasty. Regarding his humeral component, it was a small cup which covered about 50 or half of the glenosphere. His neck shaft angle was non-anatomical, or about 155, which will increase the deltoid tension and improve the forward flexion and stability. Glenoid fixation, there was bony ingrowth to minimize the micromotion, as you know. There was a compression through the central axis screws and neutralization with the other screws to decrease the micromotion. The best available bone for screw fixation is the base of the coracoid, the spine of the scapula, and the scapular pillar. Implantation angle, we should look for the most uniform distribution of the forces, which is a bit lateralized or centric with some inferior tilt. When you have an eccentric glenosphere with an inferior offset, there is some non-uniform forces. The humeral stem implantation, there is some variation, especially at the beginning, where European surgeons have non-anatomical retroversion about 0 to 10, compared to American surgeon when they put it in a 30 retroversion, which increased the external rotation, and it might be easier for conversion. As Usama said at the beginning, the most common indication or the implant was actually designed for rotator cuff arthropathy, but over the time, the indication for reverse increased for fracture, massive cuff with pseudoparalysis, rheumatoid arthritis, and so on. Complication, it's highly variable, rating from 0 to 75. Instability was one of the most common. Infection, acromial fracture, and neurodeficit due to lengthening. There is some evidence of loosening, and it's mainly due to notching, which is due to a repetitive movement in adduction and friction. So as you can see in this X-ray notching, we mean that there is some radiological appearance medially and progressively going superior toward the peg. So based on this complication, a lot of suggestions and modification was advised to decrease this notching. So 5 factors that might help to decrease notching is to have a varus humeral neck shaft angle, to have inferior placement of the glenosphere, lateral offset of the glenosphere, inferior tilt, and larger glenosphere size. So this was suggested to overcome the notching from the original Grammont prosthesis. As you can see, the base plate is placed as inferior as possible. So over the years, to overcome some of the complication and difficulties that was noticed with the Grammont implant, there was a lot of design evolution, and currently we have almost 30 commercially available implants, and which can be divided into 3 types, and now a 4th was added. So the first one is medial glenoid, medial humerus, which is the Grammont. Then the second one is the lateral glenoid and the medial humerus, which was first suggested by Frankel. Then we have the medial glenoid and lateral humerus, which most of the new implants fall in this classification. And lately we have a lateral glenoid and a lateral humerus. What do we mean when we say medialized glenoid design? We mean that the center of rotation is 5 millimeter or less from the glenoid face. Lateral glenoid design mean that the center of rotation is greater than 5 millimeter from the face of the glenoid. Medialized humerus mean that the humeral component offset is 15 millimeter or less, and lateralized is more than 15. As you can see here, when we said lateralized, we increase the glenosphere thickness. The radius of the curvature is the same, but the thickness of the glenosphere going from half a circle into 2/3 or a bit more. And when we talk about medial and lateral, we mean the long axis of the stem or the humerus and the deepest part of the polyethylene. Here it's 20, so it's a lateralized, and here it's 10, so it's less than 15, so it's a medial humeral component design. So what's the advantage of having a medial glenoid design? It will improve fixation by decreasing the stress fracture, the shear stresses. It will give you a greater lever arm for the deltoid, but as we talked before, it will shorten and weaken the residual cuff, and it will have a less deltoid wrap, which might contribute to some instability. When we have a lateral glenoid, what will happen? We're going to have a short deltoid moment arm and less efficient deltoid, but we're going to have a better restoration of the rotator cuff tension and a better deltoid wrapping. And regarding medial and lateral humerus, it will give also the same thing. So we have also now what we, the definition or the concept of global offset, which is a combination of the glenoid and the humeral, and it's influenced by your prosthesis geometry and also by your surgical technique, the way you cut your shaft angle, and if it's inlay or onlay. For Grammont, lowering the center of rotation is important to retention the deltoid. So after having all these new implant and new concept, which one we should use, which one is the best? There's a lot of biomechanical study, computeral study, and some mechanical and clinical study. Until now, we don't know what's the best, but like this study, what's the best glenoid configuration for an onlay reverse shoulder arthroplasty by Lederman? They found that if you use a 145 onlay humeral stem, a 36 eccentric glenosphere will optimize the range of motion and limit the scapular notching. What about the effect of virgin, glenoid virgin and humeral polyethylene? For onlay, neutral glenoid virgin cause the least degree of subluxation. If you have a posterior rotation, you reduce the subluxation, and if you put it in more anterior rotation, you might have increased subluxation. When we talk about the humeral neck shaft angle and the glenoid lateralization, Walsh showed that the use of 135 neck shaft angle with 5 millimeter of glenoid lateralization has the best result for impingement-free range of motion, except for abduction. What about the contact area and the contact stress when you change all these angles and lateralization? Athwal showed that there's a decrease at the average joint contact area by about 59% if you change your neck shaft angle from 155 to 135, but you have a really high contact stress, which might cause some wearing of your polyethylene. In this study by Antonio Romeo, it appears how much we should lateralize. They suggest if you're going to lateralize using a prosthesis, you can go up to 10 millimeter. And if you're going to lateralize by bone, you should go up to 5. If you go more than 5, there is a high micromotion, which might decrease the ingrowth. Lastly, here, when we talk about acromial stress, by changing the biomechanic effect, the lateralization, changing the neck shaft angle, what's the effect into the acromial stress? Also, the group with Athor showed that 5 millimeter of inferior or distal implantation on the glenoid side decreased the maximum acromial stress by 2.6. And if you lateralize by 1 centimeter, you increase the acromial stress by 17%. They noticed that humeral lateralization did not have any significant effect on the acromial stress. So, based on all these studies, in conclusion, we know that lateralization is beneficial when we perform reverse shoulder arthroplasty. The ideal amount of global lateralization and the ideal contribution from the glenoid and the humeral remain unknown. It probably varies depending on the patient anatomy, the quality and the quantity of any remaining cuff, the deltoid quality, and the amount of distalization of the humerus based on the patient and the implant prosthesis that was chosen by the surgeon. It's a huge topic. I hope that in this few minutes, you guys understand the basic principles and some of the new evolution and principles. Thank you very much.
Thank you so much, Saad, for this very nice presentation and conclusive summary for the basic anatomy and basic science behind the reverse shoulder arthroplasty. I will move on with our second speaker today, Dr. Ludwig Seebauer from Klinik am Bogenhausen at Munich, Germany. He will give us today a presentation and his thought and technique on reverse shoulder arthroplasty in cases of rotator cuff arthropathy. Dr. Seebauer.
Good afternoon or good evening. I will have
good
to
evening, sir.
bring up my slides. Okay, Usama, thanks again inviting me to this virtual meeting to Dubai. You know how much I like the United Arab Emirates and how strongly I'm looking forward to be physically as soon as possible back in your wonderful country.
And we love you, Dr. Seebauer.
Today, but we all are very nerve-wracked by this pandemic. Saad has made a wonderful introduction to the problem of reverse shoulder arthroplasty or the biomechanics. And reverse shoulder arthroplasty is still very controversial because if God had wanted that we would have a reverse shoulder, he have made a reverse shoulder, but he gives us with this tool really a beneficial tool to help many patients which were in a very bad condition with their shoulders with bad rotator cuffs. And thanks to Paul Gramont and his ingenious idea about reverse shoulder arthroplasty. I want to speak today about reverse shoulder arthroplasty in cuff arthropathy in the narrower sense, but also in all other primary non-trauma indication. As you have heard, reverse shoulder arthroplasty was primarily designed for cuff arthropathy. And this is characterized by this anterior superior static or dynamic instability of the joint and of a pseudoparalytic arm because of the loss of rotator cuff function that is characteristic for. And Paul Gramont has created a stable center of rotation despite the significant rotator cuff loss by this so-called principle of co-adaptation. And this was taken over for other indication. We have a lot of patients which have massive rotator cuff tear with or without arthritis. We have osteoarthritic shoulders which have an intact cuff, and we have now also on the list as an indication for reverse arthroplasty. And I want to talk about these three indications. I don't want to talk about any other indication like trauma, acute or post-trauma indications, failed arthroplasty, or revisions of arthroplasties. Already in 2007, Wall have shown that in massive cuff tears and in primary osteoarthritic shoulders, you can gain the same good results with reverse shoulder arthroplasty as you have with the cavity arthropathy group. But we have to look at this thing a little more closer and to understand that better. Cavity arthropathy in the narrower sense was first defined by Hamada and Fukuda, and as a consequence of a massive cavity, and was classified in 5 types. When we started with reverse arthroplasty, we want to be independent of the etiology. We only want to look to the morphology and to the stability and dislocation of the center of rotation. Therefore, we distinguish between 4 types. We have a type 1, which is characterized by a stable center of rotation, and a type 2, which have an unstable center of rotation, and type 2B is statically decentered. The type 2A is limited stable and is somehow only dynamically unstable. But what is also true with cavity arthropathy, if it is a long-standing disease, you always have to deal with additional bone erosions. You have acromial and glenoid bone erosions you have to consider in these patients. And nowadays, if we look close, that at least 30% of our patients we treat primarily with a reverse shoulder arthroplasty showing up with some type of glenoid erosions. I not count into that also the scapular spine or acromion erosion. Only the glenoid bone stock erosion is 30%. And we also have to learn that the glenoid bone loss has a very significant influence on the joint line in the coronal plane. The coronal plane is very decisive, as Saad have shown, about the lever arms for the deltoid, about all the other things like stresses to the acromion, stresses to the scapular spine, which is very important. What is the ideal joint line for a reverse shoulder arthroplasty, and of which type of reverse shoulder arthroplasty? We have just learned that we have reverse shoulder arthroplasty which have a lateralized glenosphere or have a lateralized center of rotation, and we have one which have a lateralized humerus. That are also different things we have to understand, and that is not too easy, but we have to know where it's the joint line. And the first step, if you have a good X-ray AP view, then you take the base of the coracoid, you draw a line lateral to the base of the coracoid, and if the erosion is medial to that, then you know that you have a significant glenoid erosion. And then today, it's in the area of CT scans and virtual planning with software tools. Then you can go deeper with that and to plan your joint line on that. My former fellow Ashish Gupta with his team have published a wonderful paper this year at the Journal of Shoulder Arthroplasty, Journal of Shoulder and Elbow Surgery on that, which was very good. And then you have to understand where is the glenoid bone loss, whether it's a centric or contained bone loss, whether it's eccentric or it's a combined bone loss. We already reported on that. That's a SETSEC in Rome, 2005. Later on, we published that in 2018. And we have to learn how big is the amount of bone loss. And again, today, the virtual planning, the CT readings of that is very important. Why is that so important? It's important to avoid notching. Inferior overlap gives you a better range of motion, and it gives you more stability also. If you have if you have a long neck scapula, no medial erosion, then you can do an adduction and you don't have a gapping of your prosthesis. If you have a short neck scapula and you do the full adduction, then the prosthesis will open, it will gap. You only have a point contact, and this point contact, the contact surface is proportionally to the intrinsic stability of your prosthesis. And further, if you are medial, the initial pull of the deltoid, creating not only a flexion or abduction, it makes also a lateral pull. If your humeral stem is lateral, to the lateral aspect of the acromion. This initial pull makes a flexion and abduction and a compression force. Therefore, to understand that is very important. Now coming to other indications like cuff tear arthropathy, that is a massive cuff tear in the younger patient. And then you have to distinguish between stable, compensated shoulder or unstable, decompensated shoulder. And like in this young guy, which have a subscap and also an infraspinatus massive cuff tear, which is characterized by this hornblower sign he has, because the teres is already involved, and a positive belly breast test. What should you do with him? How can you treat him? Can you do a latissimus dorsi transfer, or should you do a reverse? What we have seen, that if you have a young age patient with a high preoperative function, and then you can expect sometimes a poor functional outcome, specifically if there's neurological dysfunction. Therefore, you have to rule out that. Don't do a reverse if the patient have any axillary nerve palsy or something else. And the other thing is, you have to consider the teres minor. If the teres minor is bad, you will have this type of external rotational leg signs, that you have the hornblower sign. And Pascal have nicely shown that in these cases, and also Christian Gerber have shown that in these cases with a bad teres, you have a bad result if you don't address it. And therefore, Pascal recommended to do a very well-known procedure from the 1930s of last century, the Episco procedure, and he modified it and he improved his results. But you have to know, if you take the teres and the latissimus and you don't have any subscap, then you don't have any other muscle for internal rotation with the arm at the back, because only the subscap, the teres major, and the latissimus can do an internal rotation with the arm at the back. And therefore, we are, in these cases, we don't do a combined latissimus and teres transfer, we only do an isolated transfer. We take down only the latissimus, we keep the teres, and then we swing around the latissimus and we put it as high as possible and as lateral as possible, because this makes a better lever arm, because this is central axis of the humerus, and the higher you are, the better you reach the lateral position of the greater tuberosity, the better is the lever arm, the torque of the latissimus you wrapped around. Now it comes to another topic, osteoarthritic shoulder. 20 years ago, we have learned osteoarthritic shoulders are indication for anatomic arthroplasty. Nobody would consider reverse arthroplasty as a primary indication for osteoarthritic shoulders. But again, a French guy, Gilles Walsh, have made a basic science work, and within the last 30 years on that topic about glenoid erosion and humeral head subluxation in the osteoarthritic shoulder. And he updated his primary classification in 2016 for B3 type and a C type, and the C1 or C2 now he distinguishes between, and a D type. And what he have shown that specifically in the B3 and C glenoids, if you do an anatomic arthroplasty, and if the retroversion of the glenoid is bigger than 25, 27, 30 degrees, then you will have a bad result with an anatomic arthroplasty. Another important factor is how good is the rotator cuff. You can have, specifically in elderly patients, an intact cuff, but if you look to the muscular quality, you will find that there is already fatty degeneration, even if the cuff is intact. And some papers have shown that intact cuff with fatty degeneration makes a bad result with anatomic arthroplasty. And that is the paper Gilles Walsh have shown. If we have done a reverse arthroplasty, the complication rate was significantly lower than if we have done an anatomic arthroplasty in this case patients, and the clinical results were much better. And there's another paper which have shown that the best results you get with reverse shoulder arthroplasty is the primary osteoarthritic shoulder where the cuff is intact, but the glenoid is eroded. There you will gain the best results with reverse arthroplasty because your external rotation is better, because you still have an infraspinatus and a teres minor. You are more lateral on your joint line, and maybe you have the additional strength of the subscap, and what still is left gives you more power than with the other. Then I will show you a typical case. When I was 10 years ago, I considered this lady to be a good candidate for the primary osteoarthritic shoulder. It was a B2 glenoid, but I not taken into account her cuff quality. And what I did is another thing. You can see here, I was reaming too much medial to get my glenoid component seated well. If I look to my green line, I did an iatrogenic medialization, and this iatrogenic medialization was responsible for an accelerated degeneration of my cuff. She did well after 1 year. She decreased after 3 years dramatically. And then I have to revise her. And what I have to do at my revision, I have to do a bone graft to address the bone loss, which I initially missed or did not take it serious enough. And that is another case, 69-year-old, much younger, but you see, she had a fatty degeneration already of the infraspinatus and of the subscap, a B2 glenoid again. And I was clever enough then to do a reverse. And you see here with her right shoulder, 3 years post-operatively. And she, even with her big body, could gain a very good internal rotation. And that is her X-rays 1 day before surgery. And you could guess which type of arthroplasty I did. I did a reverse. It was a medial eroded glenoid, not a B2. That is an A2 to Schill classification. We classify that to a C3 already. And she had a global fatty degeneration index, which was bigger than 1. And here's another case, 49-year-old. I sent that X-rays to Schilvalsch and to Joe Iannotti, and they come back. Joe Iannotti was calling it a B3. Schill was calling it a C2, but we were agreeing on that we cannot address it with an anatomic arthroplasty, even with an augmented glenoid component. We have to do too much resection here of the bone stock, and this medialization will weaken the deltoid, and therefore we have to do a bio-RSA to rebuild that. And that we planned virtually on the computer. And I would like to show you another case. It's not the video of that, how we did that intraoperatively. We only reamed this anterior side. We created a bone graft as a so-called composite graft on the posterior side, and then enough length of the scapular neck. Here's our green line, enough inferior overlap, enough lateralization, and patient is happy with that. Now, what's about long-term on all these things? Luc Favre have shown with his multi-center study that after 9 years, the radiological complications or changes are increasing, not the clinical things. And that is also to see in the Australian register, that showing that after 10 years period, the reverse arthroplasty have a lower complication and revision rate than an anatomic stemmed arthroplasty. That halves the complication rate. And it have shown that one specific arthroplasty have shown really a brilliant survivorship after 10-year follow-up. And we did a study which we have now the same patients at a 10-year follow-up, and it's more or less the same results. We have seen that the results are really extremely good in the cuff tear or massive cuff tear group. And what we have seen is two things. It takes at least half year or 1 year until the patients get the full range of motion. And the range of motion, if you build in your reverse arthroplasty correctly, you can achieve really 150 degree of flexion abduction. You can reach your external rotation if you have still teres minor, and you can get enough internal rotation. What we also learned that inferior overlap is critical. If you have more than 2 millimeter inferior overlap, you have not to be afraid of a high grade of notching. And the benefit of inferior overlap already saves you if you accidentally did some superior inclination. You should avoid superior inclination. It's not a perfect position of your glenoid component, but if you have enough inferior overlap, the superior inclination is not crucial. You already have seen that we have different chances to avoid inferior notching. The prosthetic overlap, some inferior tilting is critical. Then you can use non-Grammont designs of reverse arthroplasty with a lateralized glenosphere. You can do a scapular neck lengthening by a bone graft. Pascal described that first in 2011. Or you can now do a lower inclination angle and lateralize your arthroplasty. But lateralizing has some negative side effects. You decrease your theoretical amount of abduction because if you still have a greater tuberosity and you lateralize too much, then you will have an impingement of the tuberosity with the lateral acromion. And you already have heard that a certain amount of lateralization is critical for increasing the mechanical stress on the scapular spine and increases the risk for a scapular spine fracture. Now, finally, which approach I use? Do I use a deltopectoral or an anterior superior approach? What are the benefits? The anterior superior approach has less risk or have a better residual function of the subscap and have a lower risk for dislocation, but have a higher risk for notching. On the other side, the deltopectoral approach have a lower risk for notching, but a higher dislocation rate. For us, the decision in primary indications, revisions I do all my revisions I do deltopectoral. But in primary indication, one issue is how good is the CA arch. And if I have an ossacromiale, eroded acromion, I don't do a superior approach. But here, my minimal invasive anterior approach only has a few critical things, a very short 5-6 centimeter I take off the CA ligament with a piece of bone. I make, and then the release of the triceps and the inferior capsule is very critical, because if you don't release that well enough, the prosthesis cannot go under that. And that is important. That gives you the intrinsic stability. The reducing of the prosthesis is more or less automatically by itself if you have done enough inferior capsular and tendon release. And you also should ream only inferior into the subchondral bone. Superiorly, you only should remove your cartilage. Don't take away the bone superiorly. Then you avoid superior inclination. By this small approach, it's a little tricky to do the implantation of the glenosphere, but the self-reducing, if you only a slight fingertip and then it reduces it itself. And then if you have done the releases well, you get really extremely good external rotation. And then the reattachment, you have to take firmly your piece of bone with the with the fascia of the deltoid, the deep and the superior layer, and then you really get a very good fixation also. On the other side, the deltopectoral, you already have seen more or less the approach is easier, but again, if you do the deltopectoral approach, if you do your reaming, I keep my subscap, I reattach it again, enough capsular releases around, and then I remove always, before I do my reaming, the inferior osteophytes. I look to my X-rays, to my CT scans to know where I remove the osteophytes, and then I put my template to the correct position. And when I do my reaming, you see, I don't ream superiorly, I only ream inferiorly. I only ream inferiorly, anteriorly, because the erosion of the bone stock is superior posterior. And that is not a very significant medial eroded situation, as you have seen in the initial X-ray. I only did about 50 or 30% of reaming. I drill the superior surface, and then I take some cancellous bone superiorly behind my metagland, and then I bring in my metagland. And then the rest is like at the other side. And then again, to bring in the glenosphere, and then you see, this is not a significantly medial eroded situation, so I did not have to do a structural bone graft, like in the other case where I have taken the cortex and the cancellous bone of the head. Here I did some posterior superior bone grafting, and again, enough inferior overlap. You see, you also have the neck of the scapula is long enough. Yes, and if you all follow this rule, then you can gain this situation. This is a 75-year-old gentleman with a bilateral advanced cuff arthropathy. He was a member of the German national swimming team at the Olympic Games in Rome, 1961. I don't know when it was exactly, but he's still with 75 years, still swimming every day, 1 hour or 1.5 hours, and he do that with both shoulders treated with a reverse arthroplasty. I would like to invite you to come physically again back to Munich in October 2022, when we report about more than 5,000 cases, experiences on reverse arthroplasty, and 25 years of experience with reverse arthroplasty. Thank you very much.
Thank you so much, Dr. Seebauer, for this very nice presentation. It's really amazing. Thank you so much for sharing your experience with us tonight. And I will move on to our last speaker, Dr. Philippe Valenti from Paris, France. He's a well-known shoulder surgeon. I'm sure all of you guys know him very well. Dr. Valenti will talk today on the subject of reverse shoulder arthroplasty in cases of proximal humerus fracture in trauma setting, and he will share with us his experience and his operative technique. Welcome, Dr. Valenti.
Thank you, Usam, for the great introduction. And I share my screen. Can you see my screen, Usam?
Yes, we can see it, Dr. Valenti.
Okay. Thank you for your kind invitation. It's always a pleasure to talk with you. And this is my disclosure regarding arthroplasty. And I would like to be very practical, because I think that many papers talk about the fracture and the reverse arthroplasty. And it's important for me to show you my practical experience on my practice regarding the fracture dislocation. We talk about the concept, the surgical techniques, and I give you tips and tricks, because I started reverse arthroplasty with Ludwig a long time ago, with debut in 1995, and maybe Ludwig remember this time. And I show you the result of a multicentric French study about 889 reverse arthroplasty for fracture, and we summarize the indication. So it's important to remember that if you use reverse arthroplasty for the fracture, with the deltoid, you restore forward elevation, but you doesn't restore external rotation. And this is very crucial that when you do reverse arthroplasty, you should repair the infraspinatus on the teres minor for external rotation. This is the great tubularities. And you have to repair the subscapularis for the strength in internal rotation. And in my experience, I love to repair also the supraspinatus. So regarding the approach, there is two approaches. For me, in the fracture, I prefer to use anterior-superior approach because many times the tubularities are displaced superiorly and posteriorly. And to catch them, if you use a deltopectoral, is very far. If you use a superolateral approach, it's very easy to catch tubularities. Take care, of course, to the axillary nerve because it's 5 centimeters below the lateral part of the acromion. I use the same technique that Ludwig. I detach the bone anteriorly with the anterior fibers of the deltoid. And after I do a split of the deltoid between the middle part and the anterior part. And after, at the head of the operation, I do a transversus repair of the deltoid, and I don't start the physiotherapy immediately, but I wait 4 weeks to obtain a good healing of the deltoid. So it's very easy. If you do a capsulectomy, you do a posterior and inferior dislocation of the humerus. You do a large capsulectomy. You use 4 retractors to see very well the glenoid. And I think that if you use this technique, you can put in good positions the base plate because it's very, very important. Sometimes I use the deltopectoral because there is an extension of the fracture to the diaphysis, and it's important to obtain a synthesis, osteosynthesis of the humerus and with the stem. And sometimes if you have operative complications like a fracture of the humerus, if you use a superolateral approach, it's not possible to go down because this is the axillary nerve, and you have to go to the deltopectoral approach. But this is very rare. Regarding the extraction of the humeral head, sometimes it's not so easy because there is a fracture dislocation. The humeral head is just below the conjunct tendon, inside the brachial plexus. Sometimes there is an axillary artery. And take care. And in my experience, if it's difficult to remove the humeral head, I do a osteotomy of the coracoid process, and I expose the brachial plexus, the axillary artery, and I remove very safely the humeral head. The second point, very important, is that when you do a reverse, you have to repair the cuff. So you use, you tag the subscapularis anteriorly with an unabsorbable suture at the junction between the bone to the tendon. I don't manipulate the bone with the clamp. I prefer to pull the strands, and I put 2 tags to the subscapularis, 1 to the supraspinatus, 1 to the infraspinatus, and 1 to the teres minor. And with all the suture, I can restore the anatomy of the cuff around the prosthesis. A crucial point is the fracture that don't remove any bone, because many times the fracture doesn't respect the calcar, and if you remove the bone medially, the risk is to put too low the prosthesis, and after you have to put a spacer. So don't remove any bone in a fracture. Regarding the glenoid component, we implant first the glenoid component, the base plate on the glenosphere. It's important to know that in the reverse arthroplasty, anteversion is very bad because you have the conjunct tendon, you have a risk of anterior instability, is very bad. you have to put the base plate 5 to 10 degrees of retroversion. More important is not too high, because if you put too high, there is a glenoid notch. If you put a tilt, superior tilt or neutral, you have a risk of glenoid loosening. And it's important to remember that the academic rule recommend to put lower the glenosphere and with inferior tilt to obtain a good compression of the base plate to the glenoid bone. This is the academic rules. And if you want to summarize in a fracture, like in a curved tear arthropathy, of course, the version of the stem, this is a special stem for the fracture, is mean 20 degrees to reproduce the anatomy. The most important is to have a good alignment of the humeral stem on the glenosphere. Regarding the base plate, we recommend an inferior tilt with a superior bone graft and with a good compression of the base plate to the scapula, flush to the inferior border of the glenoid, and we recommend to use a lateralized, metallic lateralized glenosphere to avoid a glenoid notch. Regarding the humerus, we lateralize, we try to reproduce the lateral offset and to increase the strength of the external rotators. And regarding the distalization, recommendation is to increase the strength of the deltoid 4 centimeters, between 4 to 6 centimeters, not too much distalization, but there is a risk of spine fracture. And I don't recommend too much lateral distalization. So regarding the level, the good level of the humeral stem on the retroversion, normally you can measure with CT scan preoperatively the retroversion of the native humerus, but it's not so easy. And I put the stem with 20 or 30 degrees of retroversion. If you have an old patient with a kyphosis, spine kyphosis, there is a very nice study of Morder regarding it's necessary to put more retroversion, because if you have a kyphosis of the spine, you have an anteversion of the scapula, and he recommend to do 30 degrees of retroversion of the stem to obtain more external rotation and more internal rotation. Regarding the level, it's not so easy, the level. Sometimes you can use a jig, a special jig. You don't remove any bone. If you have a calcar, you put the stem at the level of the calcar, and you see that the inferior level of the stem is at the same level of the inferior part of the scapula, or the superior part of the stem in the center of the glenoid, if you have no calcar. But sometimes you can use this landmark is 5 to 7 centimeters above the pectoralis major. And it's very important to put in the good level, because if you want to repair anatomically the cuff with no too tension, not to pull too much, because many times you pull too much, the tubularities is not so good, because the risk is osteolysis of the tubularities. You have to put very simple around the stem without any traction. Sometimes you put too low because you use cement in the diaphysis, and you can use spacer 5 or 10 millimeters. Regarding the fixation of the tubularities, I use this technique. You can use a transverse suture, or you can use a polyethylene band around the diaphysis, and you use 4 vertical bands to repair the subscapularis, supra, infra, and teres minor, and 2 horizontal bands to repair the great tubularity and the low tubularities. And you see that the direction of the suture is against to avoid a pulling of the cuff. So I do also a biceps tenodesis, of course. Regarding the potential healing of the tubularity, we use a bone graft around the stem, a special stem. We use cement for the diaphysis because there is no metaphyseal part for the fixation of the stem. And we use this system of vertical bond and horizontal bond. It's very important, the immobilization. In neutral rotation is very bad immobilization. You understand very well because you pull and there is a risk of displacements of the great tubulities, and we prefer neutral position to avoid medial retraction, medial contraction, and we don't start immediately. We put in the brace in neutral abduction during 4 weeks. We remove only for daily for dressing or to take a shower, but we keep the splint, and after 4 weeks, we do a control X-ray and we start physiotherapy. This is an example here of a woman with fracture dislocations, smoker, 4-part fracture. We use systematically a CT scan preoperatively. We don't do this surgery during the night, but during the elective procedure. And we use a reverse prosthesis. This is a patient that I saw 8 years with no glenoid notch and a good forward elevation on a good external and internal rotation. So with Pascal, David, and me, we did a symposium in 2016 in French, and we collect on 14 centers 889 reverse arthroplasty during 10 years. 80% of the people were women, and the mean age 79 years old. So this is a result with a short follow-up, 1 to 5 years, 420 patients, and you see that 120 degrees of forward elevation, external rotation 17, on the back, and you see that the absolute constant score is 57. The value, shoulder value was 70%, and the Adler score was 24. So we analyze the result with more 5 years follow-up, and the results was stable. And for 100 patients with more than 7.6 years old, follow-up with a good result. There is no bad result with the time. So in this series, this is multicentric study, we had 12.5% of complications, instability, and when you analyze, the reason is the excision of the tubularities or short humeral stem, and the length of the humerus was not restored. We didn't restore. Humeral loosening, because if you do excision of the tubularities, you increase the constraint to the diaphysis on the risk of humeral loosening even you do a cement. Glenoid loosening, it was a mistake, superior tilt or too wide, infection in 1% and 1% of humeral fractures. So we collect the negative prognosis factors of reverse in fracture of the humeral head. We don't recommend excision of the tubularities. If you do a bad reduction of the tubularities, if you have a malunion of the tubularities, you have not a good result. If you have a migration posteriorly and superiorly of the great tubularities, if you have a complication of if you have to revise the patient, this is a negative prognosis factors. More important is a positive prognosis factor in this great series: no diabetes, no disease, no cognitive troubles, no smoke, and IMC less than 30 on ASA score 1 or 2. And the surgery is very important, and we have to respect the academic roles of the reverse in the fracture. You have to repair the tubularity because you have to repair the cuff if you want to restore external rotation. Recommendation to use a specific fracture stem with a lateralized reverse prosthesis because you have to restore the lateral offset and to restore a good external rotation, and good elevation. On post-operative rehabilitation after 4 weeks, and you put the patient in the brace in neutral rotation. So last example here, 75 years old, CT scan, you see, massive, the tubularity was osteoporotic bone, and we did a reverse arthroplasty. He's a good guy, and he's very happy with good external rotation, good abduction, and a symmetric result after 5 years. So I would like to do the conclusion regarding the indication of the reverse in trauma. And the first point is that we should be limited the indications. Age is more than 70 years old, complex fracture dislocation of the humeral head, the poor bone quality, high risk of tubularities complication. If you are not sure how to obtain a good complication, I prefer to use a reverse arthroplasty on comorbidities. And the best results that you can expect if you do a reverse, if you lateralize, if you do obtain an anatomical consolidation of the tubularities and with a specific humeral stem. And we think that the results of reverse arthroplasty are more predictable and more constant than hemiarthroplasty. So it's crucial to use a good technique and to repair the tubularities if you want to restore external rotations. Thank you for your attention, and I invite you to a 24 hours online global shoulder arthroplasty in July, and we organize with Marcus the 24 hours online of shoulder arthroplasty with all the shoulder society of the world. And thank you, the Middle East, to participate to this meeting.
Thank you so much, Dr. Philippe Valenti, for this nice presentation. Thank you so much for accepting our invitation, Dr. Seebauer, Dr. Valenti, and Dr. Saad. It was really a nice webinar. Thank you so much for being with us tonight, and hope to see you in the future physically in Dubai with our Dubai Shoulder course in 2022. Thank you so much for your time tonight, and thank you for all our colleagues who attend our webinar. Thank you, and see you soon.
Bye-bye.
Stay safe and stay well.
Bye,
Thank you.
Bye-bye.
Thank you.